Life is a beautiful, beautiful thing. God's given us life, and that's why we respect the uniqueness of each person, the gifts of the different stages of life. Even people who suffer can sometimes draw people to them and draw people to what is really essential in life. We can talk about the inevitability of death as something which is a finish, which is final. I rather prefer to see death as a transition. God has given us our life. He loves us passionately all through our life, and he loves us just as passionately at the moment when our life is ebbing away.
And just as sometimes people have to wait before the child is born, and natural birth is something so beautiful and so wonderful, death is something so wonderful. It's the beginning of a new life, but it's like waiting for the child to be born again. It's like entering into new life.
I always say we accompany people when they enter the world. We are always present at births. We invite husbands into birthing rooms. And death is also a time when you accompany somebody as they leave the world. I always say there are enough of us around in the world that nobody should ever die alone. Even though you might not have a home or you may not have family, there's always somebody to care for you. There should always be somebody to care for you. And there should always be enough people around to accompany you. So I'm very moved when I hear about the volunteer who spent 7 hours sitting with the man who had no family as he died, or the cleaner who popped into the room and lit a candle when there was nobody else to do it. That, I suppose, brings us back to the essence of our humanity. So if you can develop models of care, and in the medical literature now we talk about early integration, where the teams work together. So the palliative care team becomes part of the primary team. So I'm here to give you your chemotherapy and try and help you live as long as possible. The palliative care doctors are here to support your family, to try and keep you at home for as long as you need to be at home, to manage your symptoms, your pain, your nausea, your fatigue, etc. And as you get sicker, to get more involved in your care. So there becomes a natural continuum. I think that the key thing for people to realize is that palliative care is no longer an optional extra, right? It's part of mainstream health. So if somebody has pain, or somebody has existential distress, or if you have a family that's struggling or not managing or coping or coming to terms with some of the patient's care needs, then I would say it's mandatory really that you consider a referral to our team. So palliative care would be defined as the holistic care of somebody with a life-limiting illness. And when we use the term holistic care, we mean not just care of their physical needs, but care of their spiritual needs, their psychosocial needs, the care of their family, the care of the circumstances of their living. So we care for the person in their totality, for the person as opposed to the patient. The other important shift in the definition of palliative care now is that we treat people early on in their disease process if they have a life-limiting illness, as opposed to just at the end of life, and well into the bereavement continuum. So you treat people from the point of diagnosis, when you know they have a life-limiting illness, right to the point after death, where you continue to support the families that's left behind. I think it's really important to understand that palliative care is fundamentally about teamwork. And you need to have a large group of people with the right skill sets. So doctors, nurses, psychologists, pastoral care workers, creative art therapists, music therapists, and art therapists, volunteers, bereavement support workers. And we also work in what we call an interdisciplinary manner as opposed to a multidisciplinary manner, where we realize that our skill sets overlap.
It's not enough ever just to have a roof above your head and 3 meals a day. Life is much more profound and much more encompassing than that. That can be given and supplied anywhere. There are cases of isolation, cases of loneliness, where perhaps they haven't had much consolation family-wise. That does happen. And again, I think our role is one to be there for them. And normally it is something that the resident will find quite soon after they come into a place, we hope, like ours, that they have found a new family. I noticed that the last couple of residents who have been very ill and all that, the other residents come in and visit them. They form bonds of friendship when they do come into a place like ours, like a lady who had her husband who died yesterday. One of the residents was sitting there for a long time. Another one came in and out to visit. So this isolation can be helped to be overcome by forming bonds of friendship. When it comes to the moment of a person dying, at the end of their life, we try to support the family as much as the resident, nearly, because the families are usually never quite prepared. Nobody is prepared, really, for the last moment. Everyone's death is so unique. It's such a sacred moment.
And the challenge arises when you have a curative intent approach to a point where you have nothing left. Many patients say to me, we feel abandoned by a primary care doctor.
On the other end of the spectrum, it's felt that we have to stay alive, come what may. God doesn't want that. The church is not asking that. We're asking that we do all we can to relieve suffering. We're not expected to take what I think it was Pius XII used to say, extraordinary means.
Often I've come to be in hospitals where there's been tremendous pressure to go on using respirators, to go on using medication, to be almost force-feeding people, which of course is a violence to a person as their life ebbs away. I think it is important medically to recognise the various stages of life and to recognise when death is approaching. And it's always been the Church's teaching that we keep people comfortable, we give them hydration, we give them as much nourishment as they can tolerate, but at the moment that nourishment becomes burdensome, there's no requirement to go on pushing. Rather, it's a transition.
And how do you facilitate that transition? The sophisticated way of doing it is to amalgamate the journey. That the two occurs as a continuum of care where there is a gradual then withdrawing of one and introducing of the other. Really, you should always continue to involve the primary care provider because ultimately care of the dying is everybody's responsibility. It should not just be the responsibility of the palliative care team. An advanced care plan is about ensuring somebody's care needs are fundamentally listened to and respected, really, that we honour somebody's wishes at the end of life. And the key thing about advanced care planning is to realise that it's a process. And like any process that involves behavioural modification or change, you have stages of pre-contemplation, contemplation, before you can actually actuate or document something. People need to think about these things. They need to talk about it. They need to bounce in and out of it. They need to put it aside and come back to it. And we are starting to realize that we have to move away from directives that are limited to life-limiting treatments to actually start this conversation about how do I want to be cared for, where do I want to be cared for, and what are the things that are important to me at the end of life. And the reality is when you are sick and you're getting sicker, there is a lot more inning and outing and modification of your decision making. So you need to have it determined as a fluid process. Fundamentally, there are some core things that will underpin it, predominantly your values and the people that you trust to make decisions for you. But there are other bits that need to be allowed to be altered or changed, as people move through the course of their illness.
One of the things that I've thought about in pretty much probably the last 20 years in my legal career is fear. I think for a lot of people, the process of dying and talking about death is also something which is surrounded by a lot of fear. It's understandable that we're afraid of it. You need to talk with people, your loved ones, your dear ones, or if you don't have anyone, your doctors or whoever, about what you're afraid of with regard to dying and so to conquer those fears and to face them Now, palliative care is very focused on dealing with that kind of discussion.
But normally we know the residents' wishes for the end of life. It's something that we do need to know. And some will tell us very clearly, I don't want anything that's going to prolong my life. I don't want to be resuscitated should something happen. Their families will quite regularly say to us, please note that neither we nor my mum or dad want my mother to go into hospital to go through unnecessary treatment.
So there are many misunderstandings about the use of drugs at the end of life, and people don't understand the differentiation between good pain management and a natural death versus euthanasia, physician-assisted suicide. And the fundamental ethical principle behind that differentiation is the concept of intent. When you commit euthanasia or physician-assisted suicide is facilitated, the intent is to end somebody's life beyond its natural means or processes.
Now, normally in our society, when we talk about an act deliberately causing death, it's like I pick up a gun and I intentionally point it at you and pull the trigger. We call that murder. Are we going to move the intentional killing of somebody, because they request it, away from the criminal law? Once you cross that fundamental line, once you break that fundamental taboo that we don't support the killing of people within our society, that's when you enter into very dangerous waters.
And the reality is people do say to us, I want to die. Can you not, this is unbearable. Life is not meaningful for me anymore. The mistake we make is we translate that to a request for euthanasia, when actually what somebody is doing is they're expressing a desire for death. So people say one of three things. They say, I want to die, let me die, or kill me. I want to die's are saying that life as it is unbearable. My suffering is unbearable because my pain is too difficult or my spiritual anguish is too hard. The death must be a better outcome. The let me die's are saying, I've lived a good life. I'm 87 years old. I don't want any more tests. Don't put me through another CT scanner. Let nature take its course. There are very, very, very few people who will actually say, kill me. But if you are untrained and you don't have the right skill set, the I want to die's, the let me die's, and the kill me's are put into a singular group. And think of the harm that we do to people. So when a request for euthanasia arises, the most important thing to do is to always address and acknowledge it. To say, you've said something really important to me, or an expression for desire for death. I'd like to be able to come back and talk to you and spend a bit more time with you. And then to try and understand, what is it about your life now that is so unbearable that death has to be the better option? And how do we as a team, and how do we as society help you through these difficult times? And not to say that actually your life is meaningless and therefore we choose to end it.
People don't need to be in pain. It's not euthanasia to give a person adequate pain control. That's not euthanasia. That's not trying to hasten a person's death to get them out of pain. You're trying to control the pain so that they're comfortable.
So the correlation between I have cancer or I have a life-limiting illness and I'm going to get morphine and I'm going to die is actually a very outdated line of thought. It doesn't reflect modern-day palliative care. And, I have patients on very, very high doses of opioids, so maybe over 1,000 milligrams of oral morphine equivalent, but used in a different drug form, drugs like methadone or hydromorphone. They're very different kinds of drugs, and they live independently at home. Some of them work. We even plant implantable pumps into palliative care patients, and they're up walking or driving. So these are the modern techniques that we utilize all of the time. In the unit that I work in, 50% of patients go home. So they come in for difficult pain or difficult symptom managements, and we tinker and titrate and really refine their drug regimes, and they discharge home to continue to live. So that this fear of opioid phobia or of fear of if I get this cancer or this end-stage Parkinson's disease and I meet a palliative care team, I'm going to get morphine and I'm going to die, is really an outdated view that we have to move away from.
I certainly understand that there are some cases, let's call them hard cases, where you have a person who wants euthanasia and they might tick a lot of the boxes that are generally made in argument. And they might say, well, that's a right that I should have. But there are rights everywhere. And society has rights too. And the weak and the vulnerable and the voiceless have rights too, even if they can't articulate them.
Sometimes focusing on patient autonomy and individual decisions and wants can actually detract from this can be a time where people come together and communities come together.
I think in our Christian understanding, we speak of freedom, we speak of the rights that we have, and they're always balanced with the responsibilities that we have. So our freedom is not limitless to do just whatever we like, but a freedom to act consistently with the way we're made, consistently with the author of life who loves us, and consistently also with the various stages in our life. The desire for suicide, to me, says it's all got too much. The burden is so much that people will take irrational decisions to seek to go forward to put an end to it all. We must be very, very careful to try and meet the person where they are in suffering, and then to support them and turn that despair into the knowledge that we are surrounded by love, that there is hope, that there are people who value us even in suffering, even in our despair, even in the pressures which operate sometimes when we want to end it all.
Those who teach law, those who practice law, those who make laws are obliged to understand the legal relationships when they filter down through the rest of society. If we change any significant law, then many other relationships, it's like the ripple on a pond. You have to see where the law is, where the changes are going. Now, the argument against euthanasia in this context is to say, well, if you change the fundamental relationship that killing can now be okay, the deliberate ending of a life, the deliberate termination, killing a person can be okay, then there's going to be a huge ripple effect. And I think that's the best argument against euthanasia.
I think it would make big changes, and I would see two main elements there. One would be, I think it could lead to a lack of trust. A lack of trust between carer and the person who is being cared for.
The issue of euthanasia and legislation in Australia is something that needs a lot of consideration. It's not just about the impact on the patient that requests a euthanasia. You have to consider the impact on people who are left behind, families and communities. You need to consider the impact on health professionals who are involved in decision making, who are involved in the process of caring. And you also have to think of the impact on society. What is the legacy we want to leave behind as an Australian society? What do we want to be known for? To be known for a country that cares for people who are sick and vulnerable, or a country that kills people who are sick and vulnerable? What's the legacy we want to leave our children and our grandchildren as generations move on?